Okay, welcome to all who are new here. Welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. This email will come from customercare@gotowebinar.com. You will have up to 72 hours to complete the quiz and the evaluation. Please ensure that this is done timely to receive your statement of credit. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. The recording will be available for review from our website tomorrow. Our speaker tonight is Dr. Alex McDonald. Dr. Alex McDonald is a family physician, sports medicine specialist, researcher, and thought leader in the fields of physical activity, physician advocacy, as well as health equity and policy. Dr. McDonald received his bachelor's degree from Connecticut College and his medical degree from the University of Vermont Larnar College of Medicine. He completed his medical internship at Duke University, family medicine residency and sports medicine fellowship at Southern California Kaiser Permanente, Fontana, California. Dr. McDonald currently is a member of the Southern California Permanente Medical Group in Fontana, California, where he is involved with family medicine residents and sports fellows graduate medical education. He is an active member of the American College of Sports Medicine, as well as the American Medical Society for Sports Medicine. He serves as the team physician for California State University of San Bernardino and Upland High School. He will be presenting today on the shoulder. So I am going to be screen sharing, and let me make sure that I am showing my screen here. All right. Okay, can you hear me, Dr. McDonald? All right, so Dr. McDonald's having a little bit of technical difficulty here. We're just waiting on him to get reconnected to the audio.
Hey, are you guys able to hear me now?
Yes, we are. Can you hear me?
There we are. I can.
Fantastic.
Sorry about
Welcome.
technical difficulties abound today. I apologize.
Not a problem. All right, so I'm going to mute myself, but I will let me know when to advance the slides.
Okay, perfect. All right. So thanks for everyone for joining. I apologize. We're starting a little bit late. So I guess the first thing I should say is I like to speak very quickly and I get a little overly enthusiastic. So I apologize in advance if I go too quickly. I'm also wearing a mask here. I'm still at work out here in the West Coast. So we'll go through this pretty quickly. I think this is designed to sort of be a broad overview of the shoulder, kind of common diagnoses and treatments. I teach a lot of the sports medicine fellows and some of the family medicine residents out here at Kaiser, Permanente, and Fontana, and this was adapted from a lecture I give them as well to sort of kind of give the background. So I apologize if it's a little too basic for some of you, but I think it's always a good idea to sometimes start with the basics and we can go from there. All right, go ahead and advance the next slide, please. All right, so my financial disclosures, I have 3 children who I absolutely adore and they're very expensive, but I have no other financial disclosures. Next, please. All right, so starting with the shoulder, it's like, oh, doc, my shoulder hurts, right? I can't tell you how many times you hear that a day, right? And I always tell people start with a really good history and physical. If you do a really good history, you can almost, almost guess the diagnosis or significantly narrow down the differential before you even lay hands on the patient. Because they'll usually tell you the diagnosis. The thing I love about musculoskeletal medicine is I'm a very visual spatial person. And so if you can have the patient be very specific about where their pain is, that can often help too. And when the pain occurs, and then obviously asking about onset and trauma can narrow the differential as well. And then also if they have loss of range of motion of that shoulder, both active and passive, that can be a big red flag tail. So those are kind of the 4 or the 5 kind of big things I always ask. And I always tell patients, okay, take one finger and point and touch exactly where it hurts the most, right? 14-year-old boys for some reason are the worst at this, right? I say, where does it hurt? And they just kind of rub around their entire shoulder. I'm like, well, that doesn't help. Take one finger and point to where it hurts the most, right? And now sometimes they can't always do that. But if you really trying to press them, most people can give you at least narrow it down somewhat too. All right, next page. Next slide, please. All right, so when you think about the anatomy, right, that it always comes back to anatomy. That's the most important thing. So if you think about sort of the main components of the shoulder anatomy and the rotator cuff specifically, in the front you have the subscapularis, superiorly you have the supraspinatus, and posteriorly and inferiorly you have the infraspinatus and teres minor. And then you also have the bicep tendons, the long head, which kind of goes up into the intercapsular space and inserts on the superior labrum. That's always important to remember that anatomy. And also the short head of the biceps going up into the coracoid process too, just to remind everyone of their anatomy. Next slide, please. So the things that kind of make me pause when I'm doing a history, and I sort of say stop, and I think, okay, we need to do something different here. We need to expedite this. We can't just sort of give this some time, or you know, in your situation, if you're seeing someone in the training room or on the field or in your office, that they basically, you know, you need to get them to see a sports physician pretty rapidly. So if they're having distal numbness or weakness in the hand or the fingers, and not like, oh, it hurts when I pick up a coffee mug, like I can't pick up a coffee mug, or I can't lift my arm. Those are things that really make you worried. If when you're lifting their arm, they just basically collapse and they have sort of drop arm, those are signs of a complete a massive rotator cuff tear. If they can't touch the opposite shoulder, that's kind of my quick down and dirty test on the sidelines. If I'm worried someone has a dislocated shoulder, if they can't, like say you're worried about the right shoulder, if they can't take their right hand and touch their left shoulder, then that's basically a dislocated shoulder until proven otherwise. If they can touch their shoulder, chances of it being dislocated are probably very, very low. I mean, obviously they could have some major pathology in there, but chances of it being dislocated are pretty low. And then obviously if it's an acute injury, then you obviously need imaging and emergent workup as well too. So those are kind of the four big things. When I hear those things, I stop and I let the other things go to the wayside, and I make sure we kind of get them the expedited care they need. Next slide, please. All right, so the shoulder. The shoulder is like a golf ball on a tee. If you can click next, please. So I always show an x-ray to a patient. Anytime I'm explaining the shoulder anatomy to a patient, I always turn their x-ray sideways. And I say, look, it's like a golf ball on a tee. The humeral head is the golf ball and the glenoid is the tee, and the scapula there. And this, basically I tell people, if you put a golf ball on a tee and hold it in your hand and try and walk down the hallway, chances are it's gonna fall off, right? And when I describe this anatomy to people, they sort of understand, okay, so those muscles and those tendons are much more important, right? I always say the golf ball on a tee has great range of motion, huge benefits in terms of active and passive and range of motion, but the downside is that higher risk for injury and instability as well too. So I always kind of start with this anatomy with patients. People tend to think of their shoulder kind of like the hip, kind of like a ball and socket, but it's really not a ball and socket at all. Next slide, please. All right, and then next, perfect. And that's just to remember the muscles again. So the supraspinatus on top, subscap in front, the teres minor in the back, and then the infraspinatus behind. Next slide, please. And then you kind of drill down a little bit deeper. You can see the thing about the bursa. The subacromial bursa is kind of the most common culprit here, but there's lots of bursa all over the shoulder, which can cause issues. And then that long head of the bicep tendon that kind of comes up the bicipital groove and inserts at the superior edge of the labrum right there. And then next, please. And then the bony anatomy, obviously, right? So the glenohumeral joint is probably the biggest issue here, but then the AC joint or the acromioclavicular joint can be a culprit of pain and instability as well, particularly for some older folks. Next slide, please. All right, so shoulder exam. So I usually will show someone a shoulder exam and do a volunteer at this part. But it's a little bit hard over a webinar, so we'll sort of talk our way through it too. So again, it's kind of being systematic about the exam. I remember when I first started learning the shoulder exam, I was just sort of kind of overwhelmed, right? There's so many maneuvers and tests, and they all have different eponym names, and it's, you know, I'm going to invent the McDonald test one day just so I can torment people learning sports medicine in the future. No, I'm just teasing. So again, kind of being systematic initially until you sort of get into a flow, and just kind of doing the same thing over and over again, because it's really easy to miss tests on the shoulder exam because there are so many different provocative maneuvers as well. So I'm going to kind of talk through my my basic exam here. So again, I start with palpation. I basically palpate from the clavicle all the way along the clavicle to the AC joint. I'll palpate along the spine of the scapula in the back, and then I'll palpate on all the musculature. Particularly, I'll press on the coracoid in the front. I'll press on that bicipital tendon, the bicipital groove, and then I'll press on the kind of just lateral off the edge of the acromion, right where the supraspinatus inserts as well. So I'll palpate kind of all along that way. If there's any particular tender spots, then I'll also obviously make note of that too. The other thing too is even just walking in the room, you can see how the patient is sitting. If they're sort of like hunched forwards and slumped forwards and their shoulders are kind of anteriorly rotated, that can tell you a lot of information right there too. Particularly a lot of football players who are like really big guys, they kind of hunch forwards, right? And that can tell you a lot about sort of not necessarily the anatomy, but sort of the musculature and the imbalance between their muscles as well too. So I guess even before I palpate, I obviously look at them and see what's happening. Then I'll have them basically range of motion. So I'll have them flex the arm all the way above the head in the frontal plane and back down. I'll have them come up to the side and basically abduct the arm all the way up above the head, all the way down. I'll have them looking from the front when I do that, and then also examine them from the back when they do that too, and see if they have a lot of extra motion of their scapula and see what their scapula motion looks like. Keep in mind the scapula, once the arm gets to about 90 degrees, kind of parallel to the floor when they're bringing it up to the side, at that point the scapula really shouldn't move. And then once you start bringing that arm above parallel to the floor in the lateral plane, the scapula should sort of rotate upwards too in a sort of a lateral plane. You shouldn't really have much anterior posterior motion of that scapula. If you do, that's a good sign. There's some weakness of the rhomboids and the scapular stabilizing muscles as well too. Then I'll have them put the elbows to the side, and I'll basically have them externally rotate the arms as far as they can go. And that right there can tell you just their passive range of motion. So I mean, their active range of motion, and then I'll also kind of give them a little passive range too. If let's say you can't get all the way out, I'll try and actively externally rotate the shoulder a little bit as well too. I'll have them reach behind them and can reach to the highest vertebrae they can on their back and testing their internal range of motion. From then I'll go to the rotator cuff muscles. So basically what I'll have them do is, again, hold their elbows to their side, and I'll have them try to clap against my resistance, so testing internal rotation strength in the subscap. Then I'll have them, again, with the shoulders to the side, actively external rotate and kind of push the fist out to the side against resistance and external rotation. And then I'll have them do Jobs or empty can test, where you bring both arms in front of you to about parallel to the floor, turn the thumbs down, and then bring those elbows or hands about 45 degrees, and I'll have them press up, and that tests the supraspinatus tendon. Then I'll also have them do the Hawkins maneuver, right, where you have I always think of it like a hawk, right? You kind of lift their arm, flex their arm straight forward to 90 degrees, bend the elbow 90 degrees, leave that elbow right there, and then kind of internally rotate by dropping that hand down and seeing if they have impingement of Hawkins. And then I'll bring the arm across and do cross arm abduction to see if that irritates their AC joint when you compress the AC joint. Those are the main motions, or the main provocative tests I'll do. Sometimes I'll do instability. I'll have them lay down on their back, and then I'll bring the elbow up, kind of like a throwing position, and I'll bring the hand up, and then I'll actually actively externally rotate that, and I'll push their hand backwards like they're cocking back to throw a ball. And if that bothers that shoulder, then I'll give them a little anterior pressure on their humeral head, and I'll see if that minimizes the pain as well. So apprehension, and then the relocation test as well. And then sometimes I'll do, depending if I'm more about the bicep, I'll do speeds test, where you have them flex and you have them kind of push on a resisted elbow and try and make a kind of do like a bicep curl against resistance too, and that can tell you if the bicep is irritated. Those are most of the main tests I do. I know it's not as helpful just kind of to me telling you about it, but you know, you can, I'm sure you all are well versed in the shoulder exam, but it can be complicated. Go ahead and next slide, please. All right, so we're not going to do a volunteer, but basically these are kind of the main ways I break it. I'm a lumper as opposed to a splitter. I like to think of my brain as very simple. I can only think of like 3 or 4 things at a time. So I always think about palpation, range of motion. I'll think about the rotator cuff specifically. I'll think about my apprehension, relocation, and then other special tests, which we didn't really get into here, but I'm sure some of you know many of those. Okay, next slide, please. All right, so here are the common diagnoses, right? So, you know, think about the common things. If there's a guy who walks in with a bow and arrow sticking out of his shoulder, it's probably the bow and arrow sticking out of his shoulder, right? So I always like to tell people sometimes the answer is a little bit more obvious than you think, and you're trying to think of all these fancy differentials, and sometimes the gut is, or the most obvious answer is the right one. So thinking about rotator cuff syndrome, and this can be a very broad term, as we'll talk about in a minute. Particularly thinking about the supraspinatus, which is probably the most likely rotator cuff which is injured in folks over 35. And then there's the subscap as well, again, in the front there, which is more commonly injured in younger individuals as well, too. Next kind of common thing I think about is sort of poor biomechanics, or sort of like I think about a kinetic chain dysfunction, right? They come in with neck pain, but it turns out that it's their shoulder which is causing them issues, and then their trap is they're hunching up their shoulders, and their trap is overly irritated and activated because they're not able to really utilize the rotator cuff muscles. So poor biomechanics is a very, very common one we see, especially in younger athletes. Arthritis, osteoarthritis, glenohumeral and AC joint arthritis are very, very common, especially in folks over the age of, more commonly, probably 40 or 50. If you're seeing a lot of arthritis in 40-year-olds, they probably had some kind of a severe traumatic injury in the past. Dislocation, obviously, it's a big one on the sidelines of any kind of athletic event. Bursitis is not very common in younger athletes, but certainly much more common in sort of mid to late age. And then obviously bicep tendon rupture. Again, I had a friend who had a distal bicep tendon rupture. He's only a year or two older than me, and I like to refer to it as the old man injury, and made fun of him mercilessly forever after that. So the bicep tendon rupture, that's pretty rare in younger individuals, but as you kind of get to 40 or 50, it's a little bit more common, and definitely over that as well. Right, next slide, please. All right, so rotator cuff syndrome. Michelle, you can just click through all these. There's a bunch of things on here. So basically, think about it like a rotator cuff tear, bursitis, supraspinatus, tendinopathy, bicep tendinosis, tendinitis, tendinosis, subscapularis dysfunction, tendinopathy. These are all impingement. These are all the same. It's all the blanket of the same term, right? Basically, I tell my residents, if a patient comes in with shoulder pain, and there's nothing like broken significantly, if you diagnose them with rotator cuff syndrome, 9 times out of 10, you're going to be at least partially right. So you can think about all these sort of subcategories, but I kind of think about kind of rotator cuff syndrome as sort of a blanket term, and then you can get more specific and more detailed as you go. But if they have some degree of instability, if they have impingement, if they have weakness, if they have inflammation of one of those tendons or the bursa itself, basically kind of rotator cuff syndrome is how I was taught to think about this as sort of the broad term overall. All right, next, please. I think there might be a few more in there. Yeah, laxity, instability, calcific tendinopathy. It's all rotator. Okay, so thinking about kind of rotator cuff specifically, these are kind of the sort of 3 stages of how you can think about rotator cuff tendinopathy, right? It's not actually a tendinitis, so tendinopathy is the term I like to use. So again, you have a normal shoulder there with the bursa, and then you can get compression of the subacromial space, and you can get either an overuse of that supraspinatus tendon in this case, or impingement where you actually lost some space between the humeral head and the acromion, and you kind of compress that subacromial bursa and the supraspinatus tendon, and then you can start to get kind of micro tears in that tendon as well, and they could progress to a complete tear as well too. So kind of the rotator cuff, there's multiple degrees of degeneration within the rotator cuff as you think about it. Next slide, please. All right, so this is an example. I usually will, during my resident lecture, I'll kind of ask any brave soul what this is, and invariably someone says avulsion fracture of the lateral humeral head, just because they want to sound fancy. But really, it's just a chronic tendinopathy of that supraspinatus tendon, which has caused some calcium deposits in there. So it's a calcific tendinosis or calcific tendinopathy of the shoulder. Pretty common in folks, sort of middle-aged folks, I'd say, 40s, 50s, and above. Next slide, please. All right, and then there's just complete tear of the rotator cuff too. If you're seeing the humeral head abutting up against the subacromion and there's no space there, then basically there's a complete tear of that rotator cuff. This patient obviously has some pretty significant arthritis of the glenohumeral joint as well. You can see the arrow there is pointing out some osteophytes. But this basically, I don't know how much X-rays you guys look at, but if you have the ability or opportunity when you're looking at an X-ray like this, you get a lot of information on X-ray, even though this is not truly a bony problem, you can get a lot of good information from the x-ray regarding the soft tissues. Next slide, please. So this is kind of what happens, right? When someone has a tear of their supraspinatus, again, thinking about that golf ball and the tee, right? So those rotator cuff muscles, when they're all working properly, are holding the center of rotation of the humeral head right in the middle of that glenoid there, and it's causing a compressive force into the glenoid, so it stays right, that golf ball stays right in the tee. When one of those rotator cuffs tear, and most commonly it's the supraspinatus, it basically has an unopposed deltoid activation, and so that deltoid actually will cause the glenohumeral, the humeral head to move superiorly, essentially, and actually pull it out of the proper kind of center of rotation of the glenohumeral joint as well. So this is very common in a massive rotator cuff tear, or just someone who's got so much chronic tendinopathy, they just have extreme weakness. Next, please. All right, posture. Remember how your mom told you to sit up straight at the dinner table, right? Well, she wasn't lying. I can't tell you how many times I walk in, and myself included, I use a laptop in clinic, and I'm sitting there on the stool and I can feel myself hunched forwards, right? So, you know, this develops kind of what I like to call lazy neck syndrome, where your kind of shoulders are hunched forwards, you're kind of extending the neck as well, and it just wreaks havoc on the deep cervical extensors and the levator-scapulary muscles of the posterior chain, essentially, and you get weakness of the rhomboids, the pecs get tight, and the anterior shoulders roll forwards, and it wreaks havoc, and then it basically kind of causes compression of that subacromial space, and this basically makes you a setup for supraspinatus tendinopathy and compression and impingement. Next slide, please. So I actually will show people this picture pretty often in clinic too. So when people are sort of sitting up properly or standing up nice and properly, their X and Y axis of that shoulder and that neck are nice and vertical, versus when you develop this sort of lazy neck syndrome, you start slouching and your chin starts protruding forwards. You develop all kinds of issues. You compress your subacromial space. You weaken the rhomboids. You tighten the anterior deltoid as well as the pec muscles as well, and it basically just is a setup for all kinds of biomechanical issues and kinetic chain dysfunction. So the number one thing I do when a patient comes to me with shoulder pain is I look at them and I see how they're sitting, right? Before when I first walk in the room, right? You know, sometimes people are on good behavior when they know the doctor has examined them, so they try and sit up straight and do everything. So as soon as they walk in that room, I look at their posture before I even do anything. Now, some people will sort of sit up straight, but eventually, over the course of a conversation, they start to slouch back to their normal position. Next slide, please. All right. So this is just going to show kind of my common rotator cuff rehab exercises I recommend. So you can click next, please. These are kind of quick, down and dirty. I usually like to only give people about maybe 4 or 5 exercises because I know they're not going to do more than that. Particularly younger athletes who are really busy and they don't like doing kind of what they think of as sissy exercises, right? They kind of like doing the heavy lifting and other kind of maybe more aggressive exercises. So first thing is shoulder rolls, just kind of all throughout the day. I always tell people stretching is great, but you really need to stretch for 30 seconds, 3, 4, 5 times a day to retrain that Golgi body and that Golgi apparatus to make sure those muscles are pulled to the proper length. So shoulder rolls, I'm a huge fan of the shoulder rolls up, down, and back all throughout the day. Next slide, please. And I tell people you can do this in the car, you can do this in line at the bank. Scapular squeezing, right? Most people, their rhomboids are very weak and their deep cervical extensors are very weak. So really thinking about squeezing those rhomboids together. And again, this is something you can do driving in the car, it's something you can do standing in line, something you can do easily throughout the day. You don't necessarily need any exercises to do that or equipment to do this. Next slide, or next, click next. External rotation. This is probably one of the most important ones to strengthen the external rotator cuff to help pull that shoulder back into the appropriate position. Again, because if you're anteriorly rotated, you have some weakness and some laxity of the infraspinatus and the teres minor as well. So that external rotation. And I tell people you're not like going to town, right? I tell people to do nice shoulder rolls up, down, and back, thinking about taking your scapulas and kind of squeezing them back and down towards your bottom, and then holding nice, steady, smooth and steady exercises where you hold it for about a nice count of 1,001, 1,002, 1,003, and then kind of slowly let it come back in and then slowly come back out again. Next, please. And then internal rotation as well, not nearly as important as the external rotation, but internal rotation also. Next, please. And then this is one I like adding too, where you kind of just, you're doing sort of isometric contraction, particularly the posterior one where you're kind of driving that elbow backwards into a wall, or something. I tell people when you're driving in the car, you can kind of push it backwards against the driver's seat or whatever seat you're in. It's nice and easy to do any point throughout the day, just to get some isometric contractions of those muscles as well. Next, please. I think there's one more on there. Oh, nope, never mind. There's not another one on there. So those are the kind of the main exercises. Now there's lots and lots of variations and derivations of those, but I found those are like very simple, very basic. It doesn't require any equipment. And you know, there's all kinds of variations. I'm sure you're all well versed in some of those other ideas too, but those are kind of my favorite I give to folks. So rotator cuff treatment, obviously. So strengthening, and stretching is the #1 thing. You can do Tylenol or NSAIDs. There's more and more research evolving about how you actually don't want to suppress the inflammatory process, particularly in an acute injury. You don't want to ice it. You don't want to do NSAIDs. You actually want to heat it and you want to move it, right? Which I know is sort of sacrilege. We've all been trained with RICE, right? Rest, ice, elevation, compression, and NSAIDs. And that's probably the exact wrong thing to do. It helps feel better, but it actually probably doesn't allow the body's natural process. So even though we still do it, there's more and more information evolving that actually after an injury, particularly a tendon injury, heating and range of motion are probably the most important thing. I kind of lean towards Tylenol for pain relief as opposed to NSAIDs because you actually want that inflammatory process. Some of the stuff I'll talk about later kind of involves producing an inflammatory response as well too. You can do topical NSAIDs or capsaicin. You can always do an injection to these shoulders. Obviously, I assume most of you are not doing injections, but you know, certainly a good option too. Sometimes I try not to do injections. I'm a less is more kind of person. So I basically won't do an injection unless someone's having like horrible pain. It's been going on for probably at least 6 weeks and they just can't sleep. They can't even do their rehab because they're having so much pain. That's when I use the cortisone to kind of calm down their pain so that they can then do their rehab. But I impress upon them that the cortisone doesn't fix the problem. It's a Band-Aid, right? And really the rehab and the strengthening and the range of motion is what's ultimately going to fix them too. So every once in a while, I'll have a patient who I do a cortisone injection and they come back 6 months later and they're like, yeah, I felt great for 6 months and then it hurt again, right? And it's like, well, how much of the rehab did you do? And they're like, well, I did it for a week and it felt better, so I stopped. I can't tell you, it doesn't happen that often because I really impress upon the point with them, but that's unfortunately a pretty common story. All right, next slide, please. All right, and this is kind of how you do the procedure as well. Again, I just so you guys are aware, I don't know how many of you are doing any cortisone injections, but basically you kind of go in the subacromial space. So, all right, no, that's fine. So you can just go in the subacromial space, point towards the corpus. So arthritis, obviously, and this is common, occurs in folks who are older. You know, this person on the left here has severe glenohumeral arthritis. This is someone I'll definitely offer a ultra-unguided cortisone injection just to calm down their pain and inflammation and just get them feeling better. But you can see even the shoulder on the right has got some mild arthritic changes as well too. Very common. Not so much in the younger athlete, but let's say the master's athlete, right? Is that the politically correct term? The master's athlete or someone who's had a pretty significant traumatic injury and has developed a post-traumatic arthritis. I've seen some patients in their, I've seen some former professional athletes in their 30s and their x-rays look like they're 70 or 80. It's amazing how they've beat their joints up over time. So it can happen in the younger athletes. And the goal here is to kind of get these people moving and back to the sport, which they love. And in this situation, you know, rehab and strengthening kind of only goes so far. And at that point, you may think about doing a cortisone as sort of a temporizing measure as well. Eventually that'll stop working too, and they may want to think about other types of injections, Synvisc, PRP. There's a lot of information, and I wouldn't say it's evidence-based, but things like stem cell injections and things like that, particularly for knees. There are people doing that. Again, I don't do that. There's no real literature that it actually works, but there is some anecdotes out there that it really does a lot. That people really like it a lot too. So there's definitely some anecdotes out there too. Next slide, please. All right, so the things that kind of make you think more about arthritis on the exam. So, kind of, this is the one where they're going to tell me they have trouble pinpointing the spot, right? It's kind of all over. It's sort of diffuse pain. It's worse when you move the joint. It's better with rest. Oftentimes, particularly shoulder arthritis and glenohumeral arthritis, they often, not always, but almost always, often have some kind of a remote history of a dislocation or a trauma or something like that. Unlike hips, where you're walking around all day, every day, shoulders, if they have some significant glenohumeral arthritis, generally have some kind of history of a major trauma. Often the pain is, people say it's pretty predictable. Every time I do this motion, it hurts, right? Or every time I hold something this way, it hurts. Generally, it's pretty constant. It kind of often gets worse throughout the day. When it starts to affect activity, that's when they often will come see me. And it's often a kind of a constant dull aching, and you get these episodic flares. It's often seen in the setting of rotator cuff syndrome, right? So by the time people have arthritis, they often have some rotator cuff syndrome involved as well too, because those rotator cuff muscles are either weak or irritated from the arthritis, or the vice versa. They're irritated and weak, and then they had a dislocation, and then they get arthritis. So sometimes it can be hard to pinpoint, okay, which is arthritis and which is rotator cuff syndrome from those weakened muscles and instability of the muscles as well too. So it can be really hard sometimes to tease out what is what, and that's obviously where X-ray can be really pretty beneficial as well too. I didn't mention this on my exam test, but the two exams I like best for arthritis, for glenohumeral arthritis, is sort of the grind test, where you have them lift, basically you passively lift their elbow essentially to 90 degrees, and you actually will push in against and kind of actually grind the humeral head against the labrum and see if that bothers them. And then they'll often have significant pain with passive range of motion as well, not just active, but passive range of motion. If they're really truly relaxing, you passively move their shoulder and their arm around, it still hurts them pretty significantly, and there can be like clicking and popping, and even you can get like a mechanical disruption if these osteophytes, or you can get a mechanical disruption of that joint sometimes too, and they just can't move their their shoulder in a certain way as well. Next slide, please. All right, so these are kind of the pearls and the takeaways I always tell my residents. Again, the supraspinatus is the most common injured rotator cuff, and that really, the Jobs or the empty can test is really the kind of the most important test for that one. When people have AC joint pathology, if they have a separation, if they have arthritis there, it's kind of everything sort of hurts, right? Everything is kind of positive on all their exams and their provocative maneuvers too. So if like you're having trouble figuring out what's going on and kind of everything sort of bothers them, think about AC, because that can sometimes mimic lots of other things and cause other things to be worse as well too. Really, particularly in the younger people, dislocation and instability are pretty common, especially in the teenage population as well. Teenagers tend not to get rotator cuff tendinopathy. They tend to have instability, and so they have an irritation of that glenohumeral joint in the labrum, because the golf ball is kind of bouncing around the tee, right? It's not falling off the tee, but it's kind of bouncing around the tee and causing irritation. And then lastly, almost every single person who walks into my office with shoulder pain, I give them some kind of scapular stabilization and strengthening activity, almost always. Even if the pain, no matter what it is, I find that is probably the most important thing to help correct biomechanical instability or biomechanical issues and reduce additional strain as well too. So that's kind of my four big things I always think about and I always want people to think about when they're examining a shoulder. Next slide, please. All right, and then real quick, bicep tendon tears, right? There's two flavors. You can click the next, please. So this one on the left here is you can see the bulge is sort of the Popeye deformity is displaced distally towards the elbow, right? And that's probably generally a long head of the bicep tendon tear, and that's, especially an older individual, you basically leave that. Oftentimes people, who are having chronic shoulder pain and then they rupture their bicep tendon. I had a patient who was chopping wood with an axe. He was like a 78-year-old guy, really, really fit, 78-year-old guy. He was chopping wood and felt this pop in his shoulder. And he was like, "Oh, my shoulder pain got better." Obviously he had this bicep deformity and some ecchymosis and bruising to the area, so he came in to see me because he was worried. But it actually helped his shoulder because he no longer had that bicep tendon pulling on his labrum all the time. It actually was gone, right? And so I know sometimes surgeons will go in there and actually try to cause that bicep tendon to rupture, or they just screw it into the glenohumeral groove, into the biceps groove, so it's not attaching and pulling on that labrum anymore. So that's the left side. The right side, you see how the bicep deformity is more proximal up towards the shoulder. That's a distal bicep tendon rupture. And that one is probably, it depends on the patient's age and their activity, but that one our surgical folks are much more likely to repair. The reason that is because remember the anatomy. There's one distal bicep tendon, and there's two proximal. Remember, there's the long head, which goes up and inserts in the superior labrum, and there's also the short head, which goes up and inserts in the coracoid. So a proximal rupture, generally you lose a little bit of supination, and like trying to turn a doorknob, you get a little bit of loss of strength, but generally speaking, your flexion strength is the same. Now, it doesn't really cause too many issues. With a distal bicep tendon rupture, folks who are, over the age of 60, I generally say, you know what, you'll probably be fine. I just leave it unless it's really impairing their activities. For middle-aged or younger folks, I almost always recommend getting this surgically repaired because, again, there's only one anchor point on the distal bicep, and they do have much more significant loss of supination and rotational strength of that hand. You can click next, please. I think yeah. So those rarely need surgery, and then those often need surgery, depending on a lot of factors, obviously, too. All right, next, please. All right, AC joint separations. I can't tell you how many times this happens. Football player, not always football, but often football player, lands on the side. They fall to the side and get tackled, and they have excruciating pain, and they have a bump right at their superior shoulder. You can almost diagnose these without doing anything else. It's very, very common. It can be displaced pretty significantly, and there's a couple different grades depending on what this looks like. Next slide, please. Or next, I think there's something that pops up here. Right. So here are the three kind of main types. There's a fourth and a fifth type, but generally, if there's a fourth and a fifth type, they're like in the ER getting emergency surgery. So we'll just leave it at this. So type 1 is just sort of a stretch of that AC ligament, and it usually don't have any kind of a palpable deformity. Type 2 is where there's a tear of the AC ligament, and the coracoclavicular ligament is stretched, that one superiorly. And then you could have type 3, which is a tear of both those. These usually have a pretty significant bump, which is kind of poking up, and everyone's freaked out more. Do they have a fracture? These generally do really, really well without anything. Often you can kind of like tape it down or do some kind of a compression to help it kind of scar down, but they almost always have a little bit of a deformity there as well. But generally speaking, when it comes to a long-term sequelae from this, it's almost never an issue. People do really, really well with this. Sometimes a type 3 or a type 4, where all three of those ligaments ruptured, may need some kind of surgery. But the issue with this too is you always got to make sure there's not a clavicle fracture, right? So these folks need to at least get an x-ray and be evaluated. You can't just sort of assume, because every once in a while you get a clavicle fracture associated with this as well. All right, next please. Oh, and treatment for these, basically you just put them in a sling and tell them not to do anything which hurts. And generally 2 weeks later, they feel fine and they want to go run around. So that's that usually very, very common in teenagers, and generally nothing long-term with that. So these are my takeaway points. I'm not sure how much you have x-rays or x-ray abilities, but this is, I apologize, that knee thing should not be on there anymore. It's the shoulder x-rays. I always try and at least do 3 views. So AP, lateral, and then an outlet view or an axillary view as well too. So I apologize, that's a mistake on my part. And then I always tell people, when in doubt, find out exactly where it hurts the patient and look at an anatomy book. Again, that's what I love about musculoskeletal medicine, is the sort of the visual spatial component of it too. So if it hurts right in their bicipital groove, it's probably their bicipital tendon, right? It's pretty common. You know, if you guys have questions or issues, then obviously, I don't know if y'all gonna have access to email afterwards as well, but I'd love to answer any questions you have. And then obviously just practicing your exam and practicing any procedures you do as well is really, really valuable too. So those are kind of the big takeaway points. All right, next please. All right, so these are some of my, this is kind of the references I used. Dr. Ruben Born and Salas are some of my mentors who I train with, and they're all pretty amazing too. So I've always kind of picked their brains about things to go. But these are some good resources, and I stole a lot of these pictures from Google Images, so I have to thank them too. All right, next please. And I think that's all I got. Do we have a forum for questions, or is there a text box or something, or I don't know. You tell me what to do.
Yep, so we have some questions coming in. So what I'll do is I'll go ahead and read those to you. Not sure if you're able to see them or not, but that's okay. So the first question comes from, we have Dr. Russ Hostetler has joined us from Florida, and he's asking, can an injection of a long-acting, one of the canes, anesthetic, help to relieve pain without disrupting the inflammatory process in a rotator cuff injury?
Yeah, that's a great question, actually. So yeah, we think we want that inflammatory process, right? You want the macrophages to do their work. So a lot of times I'll try to dissuade folks from doing a cortisone injection right away. Using the canes, if you will, right? Both the short and the long-acting ones tend to actually show that they may be more chondrotoxic, right? Particularly for like knee injections and things like that. So for the shoulder, if you're injecting in the subacromial space, unless they have a significant rotator cuff tear, you're actually not going to get any of the cane, so to speak, into the glenohumeral joint itself, right? So you're not as worried about the chondrocyte damage. So I sometimes will use the canes alone to help with significant pain. I don't do that a lot, actually, but that's certainly a good thought, and I don't see a whole lot of downside to using those to help to suppress the inflammatory response. Again, they're sort of short acting, right? They don't last a couple hours to maybe a few days. So it's certainly something I don't do a lot, but it's something to consider.
Would you use it if you're trying to diagnose potentially the location of where their pain is coming from?
Mm-hmm. Yeah, I'll do that actually. I'll do that a lot in hips actually. If I'm not sure if the pathology is intra-articular versus extra-articular, sometimes actually I'll do a ultrasound guided intra-articular injection to determine if, okay, is this a labral issue or is this sort of a rotator cuff issue? So I will sometimes do that for diagnostic purposes. Not super often, but I have done it before.
And let's see if there's any other questions that want to come in. And while we wait for those, you've got an open floor here. You want to give us a little update on what things are going on in California right now?
Well, it's it's all COVID all the time. It's actually crazy. I practicing family medicine, I actually work in the hospital as well. So I spend about 15% of my time rounding in the hospital, 30% of my time doing sports medicine, and the other 55% or so doing primary care and teaching with the residents. So I've actually been a hospitalist the last month, pretty much. It's absolutely staggering the number of patients we have coming in, and how sick they are too. They kind of putz along for a few days with a significant oxygen requirement, and they just kind of crump. I'm actually coming off service, and tomorrow the last week I've probably sent more patients to the ICU or I've pronounced dead in the past week than I ever have on inpatient service in a week past. So it's pretty scary and pretty serious. So please stay home, please wear your mask. Please don't get together with family for the holidays, as painful as it can be. There, consider it my PSA.
There it is. Okay, we have a question coming in from Sarah. She asks, when an athlete has multiple dislocations, what factors do you consider when discussing surgical intervention?
Yeah, so there's the TUBS versus the AMBRI acronym. I'm not sure if you guys have heard that before. So TUBS is traumatic unidirectional. There's often a Bankart lesion. And those often need surgery, right? If it's the AMBRI, which is, atraumatic, multi-directional, bilateral, they're often like hyperflexible. They can like touch their thumb back to their elbow practically. Those I tend to do as much rehab as possible. And if they don't get better with rehab, then you can do a surgery. It's called an intracapsular shift, where they kind of tighten up that capsule. It's not a great surgery. I haven't had patients have super successful results with it. I think most people, respond to rehab if they're that AMBRI type, where it's kind of they're just weak and sort of loosey-goosey, Gumby syndrome, if you will, right?
All right, so Tara asks, as far as heat goes, and they wanted some clarification on when you're suggesting utilizing heat. They were asking about for an injury versus ice.
Yeah, so particularly for like some injury that's relatively acute, they've sort of been evaluated. We know there's no broken bones if there's not significant like a hematoma or a myositis. We're not worried as much about a myositis ossificans, where you can get bleeding into the muscle and then calcification. If we're mostly worried about sort of a tendon strain, then often we'll do heat. You want to stimulate blood flow to that area and then just get them moving. I think sort of ankle sprain is kind of the most common one I think of, right? When I see a lot of people who've sprained their ankles 2, 3, 4 weeks ago, and they're super stiff and they're super tight. And if those people, instead of being put in a cam boot or put on crutches initially, if they had just been heating it, working on getting early range of motion, even within a day or two after the injury, they're going to get back to activity much faster. And sort of I have to think back to my biochemical life science days, but sort of the macrophage, you want to activate the macrophages, you want to stimulate cytokine. Tendons in and of themselves have pretty horrible blood supply, right? And so then they get injured and then they become chronic, right? And if you can actually stimulate some bleeding to that area, stimulate some blood flow, you're actually going to be able to kind of start that while you have that acute inflammatory process. You actually can kind of utilize that to work on restructuring the tendons and increasing macrophage activation to get those tendons healthier and back to normal faster. Does that make sense? So not for every injury, but particularly for tendon issues.
Perfect. Well, we will go ahead and wrap up here. Thank you so much. I am glad this worked out. I know we had a little bit of technical difficulty at the beginning, but made it through, and certainly good audio, which is always impressive when we're dealing with all of these virtual webinars. So thank you very much, Dr. McDonald, and thank you to everyone for attending.
My pleasure. Thanks so much. And then if anyone wants to email me, it's alex.mcdonald, just like it sounds, at kp.org. So feel free to shoot me an email, or I'm sure you can reach out to Relevant Sports as well, and they can get us in touch too if you have any other questions or burning issues, or you find yourself in Southern California and injured, then come find me. No, I'm just teasing.
Awesome. Well, have a great night, everyone. Thanks for attending.
Thanks so much. Bye-bye.